Hello, everyone, and welcome. It's absolutely brilliant to have you all here for this high-yield clinical explainer. If you're a surgeon, a physician, or an anesthetologist managing patients heading for a liver transplant, you already know perfectly well that the stakes we're dealing with are incredibly high. The cardiovascular system absolutely takes a battering in end-stage liver disease. And getting the preoperative assessment right, well, it isn't just about ticking boxes for the surgical committee, it is literally a matter of survival. Today, we're going to do a proper deep dive into the 2024 to 2026 clinical pathways, focusing heavily on the groundbreaking ILTS and leakage guidelines. We've got a lot of highly technical, complex ground to cover to ensure our patients make it off the table and thrive long-term. Right, let's get straight into it.
Hello, anesthesiologists. Thank you for your hard work today in administering difficult liver transplant anesthesia. Today, based on the latest guidelines from international academic journals published between 2024 and 2026, I will review the latest updates on cardiovascular evaluation prior to liver transplant surgery. Namaskar, anesthesiologists. लिवर प्रत्यारोपण के कठिन ऑपरेशन में एनेस्थेटिक डीएनए में आज आपके अथक परिश्रम के लिए धन्यवाद। आज 2024 और 2026 के बीच प्रकाशित अंतर्राष्ट्रीय अकादमिक पत्रिकाओं के नवीनतम गाइडलाइंस के आधार पर मैं लिवर प्रत्यारोपण सर्जरी से पहले हृदय संबंधी मूल्यांकन पर नवीनतम अपडेट की समीक्षा करूंगी। Here is our clinical roadmap for today. We'll start with baseline assessment and pathophysiology, move into CAD risk and screening, tackle managing specific cardiac conditions, then look at emergency protocols, intraoperative and post-LT care, and finish up with a master guideline summary. Section 1. Baseline assessment and pathophysiology.
Before we can safely treat these patients, we really have to understand exactly why our standard everyday cardiovascular assessments so often fail us in this specific cohort. The physiology in the end-stage liver disease population is completely fundamentally inverted. Think about it. Portal hypertension drives a massive increase in intrahepatic resistance. This triggers an overwhelming release of systemic vasodilators. We're talking huge amounts of nitric oxide and prostacyclins flooding the system. As a result, systemic vascular resistance just absolutely plummets. Now, to compensate for this massive drop in resistance, the body goes into overdrive. It ramps up the renin-angiotensin-aldosterone system and the sympathetic nervous system to try and maintain perfusion. The end result? A profound hyperdynamic state. The heart is pumping away, generating a massive cardiac output, but it's pumping against virtually no resistance. This continuous, relentless overstimulation inevitably leads to structural damage. You get cardiomyocyte hypertrophy, fibrosis, and ultimately a severely blunted response to actual physiological stress. So, when you're assessing these patients in clinic, they might look hemodynamically stable, but their heart is essentially running a marathon on a treadmill, structurally degrading day by day.
So, how do we establish a safe baseline in this completely inverted physiological system? The 2026 ILTS and LICH guidelines are completely unequivocal here. A 12-lead ECG and a resting transthoracic echocardiogram, or TTE, are absolutely mandatory for all liver transplant candidates. There's no debating this. It is a strong grade 1+ recommendation. We are actively looking to exclude absolute contraindications right off the bat, particularly a left ventricular ejection fraction of less than 40%. If it's below that, the mortality risk is just far too high. Beyond imaging, the guidelines include a crucial good practice statement regarding routine preoperative iron and hemoglobin optimization. We know that anemia severely drives up perioperative morbidity, so fixing it early is vital. Furthermore, we need to talk about baseline cardiac biomarkers. Checking high-sensitivity troponin I and BNP is strongly advised. Now, we aren't just using these for a diagnosis of heart failure. They provide incredibly sharp prognostication of early post-transplant mortality. If those biomarkers are deranged at baseline, you know you're heading for a very rocky perioperative course.
This brings us directly to a concept we absolutely must master: cirrhotic cardiomyopathy, or CCM. The 2020 diagnostic criteria update critically refined how we view this. We define CCM clinically as cardiac dysfunction and cirrhosis characterized by diastolic or systolic impairment, electrophysiological abnormalities like QTc prolongation, which is huge, and a critically blunted response to hemodynamic stress. But here is the real, terrifying danger of CCM. It is incredibly good at hiding. Because the systemic vascular resistance in cirrhosis is abnormally low, the heart simply doesn't have to work hard to push blood forward. It looks like it's coping fine on a standard echo. The contractile reserve is actually severely reduced, but you won't see it until the patient is in theater. The moment the surgeon clamps the IVC or during the massive hemodynamic stress of graft reperfusion, that low SVR environment vanishes. The heart is suddenly hit with an enormous afterload, and that latent cardiomyopathy is unmasked in dramatic, sometimes fatal fashion.
Moving to Section 2, CAD risk and screening.
Now we are entering what is arguably the most critical and heavily debated phase of our preoperative evaluation, screening for coronary artery disease. The landscape has completely shifted over the last decade. With the rapid rise of MASH, metabolic dysfunction-associated steatohepatitis, our patients are coming to us older, heavier, and with significantly worse coronary risk profiles than the viral hepatitis patients of the past. To handle this, the latest guidelines give a conditional Grade 2+ recommendation to the CAD-LT scoring system as our definitive first-line screening tool. It's a beautifully simple but powerful clinical calculator. It assigns points based on age, sex, diabetes, hypertension, smoking history, and personal or family history of CAD. It categorizes our patients into low, medium, or high risk right there in the clinic, long before we even think about sending them down to the radiology suite or exposing them to the risks of the cath lab.
Let's look at exactly how this expert consensus algorithm plays out in practice, because the logic for escalating assessment here is incredibly strict and entirely data-driven. Once you calculate that CAD-LT score, if your patient is categorized as low risk, meaning a score under 4, you stop right there. No further assessment is needed. You don't order a scan just to be safe. The data shows it doesn't improve outcomes. However, if they land in the medium risk category, you proceed to a coronary artery calcium score, or CACS. If that calcium score comes back as 0, brilliantly, you stop again, they're cleared. But if the CACS is greater than 0, or if the patient was initially classified as high risk right from the start with a CAD-LT score over 8, you bypass the CACS and move straight to a CT coronary angiogram. Notice what's missing early on: invasive coronary angiography. That is reserved strictly for patients who have positive, high-risk features on their CT scans or massively high calcium scores, typically over 400.
You might be wondering, why this very specific step-up approach? Let's break down the modalities. CACS is fantastic as an initial imaging step because it requires literally no contrast, which perfectly protects our patients' highly vulnerable hepatorenal syndrome-prone kidneys. But it lacks specificity. CTCA is the next logical step. It's absolutely brilliant for distinguishing between stable, heavily calcified plaques and those nasty, rupture-prone, non-calcified soft plaques. We are also seeing the incredibly exciting emergence of CT-FFR. This uses advanced machine learning to derive functional blood flow data directly from the anatomical CT scan. It's a real game changer, though it still needs wider validation in our specific transplant cohorts. And what about invasive coronary angiography, the traditional gold standard? Well, while it remains the gold standard for both diagnosis and intervention, putting an end-stage liver patient with profound coagulopathy, varices, and severe thrombocytopenia on the table carries a massive 5 to 7% major bleeding risk. That is simply unacceptable for routine screening. It's a gold standard we absolutely prefer to keep in our back pocket unless it's strictly necessary for a planned intervention.
And right here is a absolutely crucial point that represents a major shift in our clinical practice. If you are still ordering routine exercise stress tests for these patients, you need to stop. The 2026 guidelines deliver a strong Grade 1+ recommendation firmly against using exercise stress testing as a first-line screening tool. Why are they so strictly against it? Because patients with end-stage liver disease suffer from severe physical deconditioning, profound sarcopenia, and chronotropic incompetence. They literally physically cannot get their heart rate high enough on a treadmill to trigger the ischemia required for a positive test. All it does is lead to incredibly dangerous false negatives, giving the surgical team a completely false sense of security right before a massive operation.
Section 3. Managing specific cardiac conditions.
Moving beyond just ischemic heart disease, our transplant candidates frequently present with highly complex structural and electrical comorbidities that require very nuanced management. For instance, if your baseline resting TTE shows significant aortic stenosis or moderate to severe mitral regurgitation, you cannot just accept that at face value. The hyperdynamic state can skew those gradients. It absolutely warrants verification with a transesophageal echocardiogram, or TE, to get the true severity. You also need to keep in mind that subclinical cardiac dysfunction is astonishingly common in this group. We're talking about it being present in up to 47% of all candidates.
To actually find it, you need to rely on global longitudinal strain, or GLS, imaging on the echo. GLS is incredibly sensitive and can unmask latent systolic dysfunction long before the ejection fraction drops. And if you do find significant coronary disease and revascularization is needed, the data shows it is generally safe if the patient has compensated cirrhosis. But you must, absolutely must, have a formal multidisciplinary heart team discussion before proceeding. Arrhythmias in this population present a really unique headache for us as clinicians. Atrial fibrillation is highly prevalent, and it significantly drives up both stroke risk and overall mortality. Management requires incredibly strict rate or rhythm control. And let me be clear, you absolutely must do a TEE before any cardioversion to rule out a left atrial appendage thrombus. You cannot risk throwing a clot in a patient awaiting an organ. Furthermore, QTC prolongation is incredibly common. It's actually so highly predictive of a 30-day post-transplant cardiac arrest that it's now a core variable in the Curry risk score. You must aggressively correct their potassium and magnesium levels. As for anticoagulation, well, it's a terrifying tightrope walk, isn't it? You are constantly trying to balance the stroke risk of AFib against the severe, life-threatening bleeding risk of esophageal varices and portal hypertension. This requires a highly individualized, multidisciplinary decision matrix, often leaning towards the very careful use of DOACs rather than traditional vitamin K antagonists. Implementing guideline-directed medical therapy, or GDMT, prior to transplant requires extreme caution. You can't just blindly follow the standard heart failure guidelines. First, clearly define if you are treating for primary or secondary prevention. When you start initiating beta blockers or RAS inhibitors, you must monitor them like a hawk. Why? Because paradoxically, these agents are actually associated with a higher risk of non-portal gastrointestinal bleeding in this specific cohort. Interestingly, statins are chronically, massively underused in our liver patients. The data clearly shows they are generally very safe in compensated liver disease, and they absolutely should be utilized to protect their vessels. However, recognizing the fragility of these patients, the full aggressive rollout of GDMT is often strategically deferred until post-transplant, once the new graft is happily functioning and the patient's systemic hemodynamics have finally stabilized. Section 4. Emergency Liver Transplant Assessment Protocols. So what happens when all our careful outpatient planning goes out the window? What do you do when a patient is sitting in the ICU with acute non-chronic liver failure, intubated on vasopressors, and listed emergently? You simply don't have the luxury of time for an exhaustive stepwise workup. In these scenarios, you have to rely on a rapid, sharp clinical assessment, a focused bedside TTE to rule out gross structural failure, and aggressively trending their biomarkers. Now, here is a brilliant, highly practical tip for your practice. When you inevitably have to send that incredibly unstable ICU patient down to radiology for their mandatory thoracoabdominal CT to assess liver anatomy and rule out malignancy, combine it with a coronary CT protocol at the exact same time. It saves a dangerous extra trip out of the ICU and yields instant, actionable anatomical CAD data. In these extremes, as physicians, we must accept higher unknowns. We have to prioritize their immediate life-saving transplantation over agonizing about long-term CAD risk profiling.
Section 5. Intraoperative and post-LT care.
To the anesthesiologist watching, this is entirely your domain, and the intraoperative checkpoints here are intensely demanding. We all know that hemodynamic volatility absolutely peaks during graft reperfusion. When those clamps come off, you are dealing with a massive, sudden flush of sterile inflammation, reactive oxygen species, and cold, highly acidic blood slamming directly into the right heart. It's a physiological car crash. Because of this, continuous transesophageal echocardiology is not just a nice-to-have or helpful extra, it is an absolutely essential real-time tool to guide your volume resuscitation and your inotrope support minute by minute. You also must be acutely prepared for sudden catastrophic right heart failure. If the patient has borderline portal pulmonary hypertension, that right ventricle is going to face a massive sudden increase in cardiac return upon reperfusion. You have to be ready to manage that pressure shift instantly. Once the patient survives the grueling surgery and the ICU stay, the cardiovascular battle is unfortunately far from over. Postoperative cardiovascular risk is heavily influenced by the drugs we prescribe. Standard calcineurin inhibitors, or CNIs, like tacrolimus, aggressively accelerate hypertension, new-onset diabetes, and severe dyslipidemia. If we aren't careful, we are essentially just trading end-stage liver failure for aggressive metabolic syndrome and premature heart disease. Therefore, shifting our protocols towards renal sparing and CVD-protective immunosuppression strategies early on, like utilizing mTOR inhibitors, combined with setting up a highly structured long-term cardiovascular surveillance program, is absolutely vital. Our ultimate goal isn't just a working graft, it's ensuring that the new liver actually outlives the patient's heart. Finally, Section 6, the Master Guidelines Summary.
Let's pull all of this complex data together and synthesize it into very clear, definitive clinical takeaways for your daily practice. These are your absolute non-negotiables from the 2026 update. Number 1. Universal baseline ECG and TTE for all candidates is a strong Grade 1+ mandate. Do it on everyone. Number 2. For risk scoring, utilizing the CAD-LT score for initial stratification is a Grade 2+ recommendation. It's the best tool we currently have. Number 3, if that score triggers an elevated risk profile, you move straight to CT-based testing, either CACS or CTCA. That is also a Grade 2+ recommendation. And number 4, perhaps the most important practice change for many units, the strict, absolute avoidance of routine exercise stress tests and routine invasive coronary angiography. That is a strong Grade 1+ directive. It is specifically designed to protect our highly fragile patients from unnecessary diagnostic delays and profound physical harm.
I'll leave you with this somewhat provocative thought as we wrap up today's explainer. We've just seen how CT-derived fractional flow reserve is brilliantly using machine learning to extract highly accurate, functional ischemia data from what is essentially a simple, non-invasive anatomical CT scan. As these AI-driven tools mature and become widely validated in our cirrhotic cohorts, do you think the risky, bleeding-prone, invasive coronary angiogram will become entirely obsolete in our future liver transplant assessment algorithms? I think we are standing on a truly thrilling frontier in perioperative medicine. Thank you all so much for your time and your incredible dedication to this incredibly complex, demanding specialty. Now take these guidelines back to your MDTs, apply them rigorously, and let's keep pushing the boundaries on the survival of our transplant patients. Take care.